Hepatitis C epidemiology. Access to treatment and care on a global level has been the task I've been given, and so here we go, not having to cover too much today. I have disclosures. Importantly, I receive investigator-initiated funding from Gilead Sciences, AbbVie and BMS for my work. So the things that I'm planning to cover today is why it's important to have access to treatment and care, setting the scene, a little bit of epidemiology. I'm an epidemiologist, so I like to do those kind of things. Hepatitis C elimination, and I guess my comment here is it's not just treatment, stupid, so we have to think beyond it just being treatment. Treatment is important, but we have to think beyond it. And what's happening though in treatment has been the task I've been given, and then I'll do a quick summary. I often think that I could give this talk very, very quickly, or many of my talks really quickly. Direct-acting antivirals work. People want to be treated. It stops people from dying. It stops the ongoing transmission of the infection. Treatment is cheap in many places. It's getting cheaper and can be cheaper. So I simply don't understand why everybody's just not receiving treatment now. On a certain level, I do understand it, but really if we just cut through a whole lot of the nonsense, there should be no reason why anybody who's got chronic hepatitis C infection is not accessing these therapies now. I refuse to take into account these arguments of treatment being expensive. It's not, it's affordable. There are ways to disrupt economies. Our countries need to negotiate better and our countries need to prioritise better as to whether treatment should be available for everybody. This is now a very affordable treatment. It's a cure. Doesn't take too long, just 12 weeks. So I think we've just got to keep that in our mind when we're having these conversations about what will we do and how we do it. Is that really, this is doable? I simply ask all the countries in the world with more than 2 submarines to give up 1. Because if they did, if you think only 2 submarines have fired anything in the last 30 years, the Falklands War, when Margaret Thatcher wanted to keep a small island somewhere a long, long way from England, and North and South Korea. And apart from that, we've got a lot of submarines wandering around. So when I'm told it's not affordable, I say nonsense, and it's not a competition with other health issues. That's just a party political statement from Margaret Hellard. Some epidemiology. Basically, lots of infection. Every time they do a new model, the numbers change. So if you want to change what's happening in the world with viral hepatitis or HIV, do a new estimate and model. But it's around 70 to 80 million people are thought to have chronic infection, approximately. So that's a lot of people globally. And it causes a significant burden of disease, and combined with hepatitis B, these days causes a greater number of deaths than malaria or HIV or tuberculosis. It's something we must take very seriously. Lives are being lost unnecessarily. Essentially what it does is it causes scarring of the liver, and people are then at risk of liver failure or hepatocellular carcinoma. It is everywhere. It varies as to the extent that it is everywhere, but there is no country. It's a bit like when HIV started and there was this sort of myth of it won't come to our country, or it won't be here, it won't be there. It is everywhere. The epidemiology can be markedly different and vary across regions, and it can be very mixed. So there are some countries where it is predominantly driven by transmission is predominantly driven by people who inject drugs not being able to access safe injecting equipment, so injecting unsafely. In other countries, it is driven by what I'll call through health systems, which need strengthening, and it might be through the official or the non-official health system where you've got reuse of equipment. In other countries, it's a combination of these. In some countries where there's HIV, particularly in gay and bisexual men, you can get sexual transmission. Otherwise, you have to work incredibly hard, I think, to get it sexually, and I always feel like congratulating people. So, hepatitis C. The Sustainable Development Goals named hepatitis C, along with AIDS, tuberculosis and malaria, neglected tropical diseases, where they said the end the epidemics. They basically talked about combating hepatitis and some others. So all of us who do a bit of HIV and a bit of tuberculosis and malaria, we decided that we would say combat was the same as end. And so we're going to combat hepatitis B and C by ending those epidemics too by 2030. And a key component, and I think this is really important to keep in mind, is that the Sustainable Development Goals talk about universal coverage. Nobody should be left behind. We're talking about equity here. WHO, encouraged by the Sustainable Development Goals and others, essentially put out their vision as a world where viral hepatitis transmission is stopped, that everybody living with hepatitis has access to safe, affordable and effective care and treatment, and that the goal is to eliminate viral hepatitis as a major public health threat by 2030. And this slide has been presented previously at this meeting, but essentially it set targets for 2030. And the idea is to stop the deaths, reduce them by 65% and reduce transmission overall by 90%. And for hepatitis C, this was a reduction in new cases by 80%. Can it be done? What it requires is that we diagnose people who are currently not enough people diagnosed. We treat more people, and as well we should not forget that we need prevention. And in the targets they actually set numbers for the number of needles and syringes that needed to be distributed for people who inject drugs, and that needed to increase markedly. Interestingly I found it, no specific information was given for increased opioid substitution therapy, where there is clear evidence these days. And so for those of you in the audience that really don't do as much work in the area of people who inject drugs, there is clear evidence that needle and syringe programs work, and there is clear evidence that opiate substitution therapy works in reducing hepatitis C incidence. For want of time, I won't go in there today. Why do we think we can eliminate? And I always say that the beginning of the models that really set us on the right path was work by Peter Vickerman and Natasha Martin at the London School at the time and Bristol University now. And in essence, they showed that we could get reductions in prevalence of hepatitis C, significant reductions in prevalence. And you didn't need to treat everybody immediately. Depending on your background disease prevalence, you could treat 5, 20, 40 people who inject drugs per year annually to reduce substantially prevalence over 10 to 15 years. So you don't need to treat everybody immediately, but you need to start to do it. Further modelling by us in Australia, because we were sort of thinking we might get universal treatment access, and I'll come to that in a moment, was that people would say, well, what happens? Should you be treating people with severe liver disease, or should you be treating people who inject drugs? Severe liver disease, you can stop the deaths. If you treat people who inject drugs, you impact on transmission. And as I said, you don't have to treat everybody immediately. But then if you do that regularly over time, you can also have an enormous effect. So when we looked at a model where we did one, where we just treated people with severe liver disease to stop the deaths, and we needed to treat about 4,500 people a year. We looked at treating people who injected drugs, and we could stop the transmission, and it was about the same number per year. Importantly, if we treated the people who injected drugs, we also stopped the deaths by the 2030, but we had more deaths in between times. So in Australia, essentially what we did is we asked the modellers to go, say if we treat for about 5 years, hammer at people who have severe liver disease and treat transmission, can we eliminate? And what this slide shows you is clearly combining those two things, a combination of treating people with severe liver disease and ensuring you're treating where your transmission is occurring, can lead to us sustaining those 2030 goals. So why has Hep C elimination become achievable? Because we have fantastic drugs. They're simple, safe and effective. And others will speak about this more in the next session, so I'm not going to go into any more details except to say that the drugs work. But the drugs, it's not just the drugs, stupid, is what I'm going to say, is you need to actually be saying, how do I get drugs to people? That means that you have to be engaging with people. It means we need to be doing testing. We also need to be doing harm reduction. You can get reinfection. So if you don't think about, number one, preventing people from getting infected in the first place, and then number two, stopping transmission or reinfection following treatment, you will run into problems. So harm reduction is essential. Our models, and again, for want of time, I won't go into it, but the models are showing that clearly. And finally, we need a vaccine. Prevention is high quality harm reduction. This means it to be there and it to be effective and it to be up at those levels. That's a combination of needles and syringe programs and opiate substitution therapy where it's being driven by people who inject drugs. But we know that this is not happening, and this essentially shows us that there is areas where there is a total lack of coverage of OST. The same with needles and syringes. This needs to change. This is highly cost effective, has been shown to be highly cost effective, and is causing people to die around the world getting infected unnecessarily with bloodborne viruses, not just with hepatitis C, obviously HIV as well. And there are epidemics, and the rising numbers in Russia and parts of Ukraine and the like are a real concern because of that lack of programs. As well, we need to recognise that hepatitis C is driven in some countries by essentially poor blood safety or infection control, both within the formal and the informal health system. And again, this is something we really need to be considering in terms of our response. The cascade of care, it's very similar to HIV. You've got to be identified, tested, treated, and cure. And what we know is we're nowhere near good at it. And we have massive fall off from people being, number one, identified, and then number two, if they are antibody positive, having an RNA test and going on to cure. So this essentially, and this is a slightly old slide by Greg Dorr, but it's a really good one in my view. It's really showing where our problem lies of that combination of lack of testing and treatment. Our work, and this is now in press, this particular piece of work, but just I want to say to people, when we looked at it in Australia and we said, well, okay, if we've got treatment, what's going to be our biggest barrier? And our biggest barrier to achieving elimination, if we had access to treatment, was actual testing. So it's really important to understand that treatment's not going to just simply get you over the line. Even if you've got universal access, you must be testing the groups at high risk, and you need to get that testing done frequently depending on your epidemic. So in Australia, for us, we need to be having testing going on in community, at least annually, in key risk populations. There is, at the moment, really poor evidence, and the WHO guidelines show this, there's really poor evidence about what's the best approach. We need more quality implementation science studies around rapid point of care testing and the like, but certainly we need more testing. I don't mind whether that's a finger prick, a blood spot, a Cepheid machine, it goes to the machine in your big lab. We just need more of it happening. And in terms of the model of care for treatment, again, there is a lack of high quality evidence at the moment as to where treatment should be occurring. But increasingly it's being shown that treatment is effective when people do not have to go to big tertiary hospitals, but the vast majority of people can be treated in community settings. The reason that this is good is, number one, it's invariably cheaper. Number two, many countries don't have the capacity to treat large numbers in their tertiary hospital settings. And number three, when you look at the cascade of care and you say, where do we lose people from that cascade of care of between testing and treatment, is they get lost on their way to the big tertiary hospitals. We see this with HIV, and we think, and sort of preliminary data from some of our work in the randomised controlled trial is certainly suggesting it's the same with hepatitis C. It's not that people, they just find it hard to go from point A in the community to the big tertiary hospitals. So no one model of care has yet been proven to be beneficial or not. I think over the next few years we will show better evidence to treat where possible in community. You need to measure the liver scarring, but again, a pre-test, a simple pre-test can do this if you don't have access to the FibroScan machine. These things can be made simple and should be made simple, and all country plans should have simple country plans as possible. And lest we forget, in my view, we do need a hepatitis C vaccine, and the reason for this is if we can get a cheap and affordable one in the countries where we are going to really struggle to have high quality harm reduction, it's important. As well in countries where transmission is through the official and the non-official health systems, where it's going to take a long time to get some of that under control, this will also be important, where we could then treat somebody and then immediately vaccinate somebody. Modelling by my group, by Nick Scott and Heidi Drummer, who's working on a vaccine, and myself, have clearly shown the effectiveness of the combination of treatment and a hepatitis C vaccine. And the thing is, it doesn't need to be a perfect vaccine. We don't have to aim for a vaccine of 90% efficacy. What our work has shown is a half-decent vaccine. Now, the companies won't go for a half-decent vaccine, so let's go for a more than half-decent vaccine, but not a perfect vaccine will be really, really effective when done in combination with treatment. So we need to stop the conversation about vaccines not being required. I think they'll be vital in many, many countries, particularly those which will struggle with harm reduction or health system strengthening. So treatment access globally, what's happening and where? Achieving elimination is only possible if people can get these drugs. It's not the price, stupid, but it is the price. The conversation, in my view, started off in the wrong place about 3 or 4 years ago in terms of people thinking these drugs are expensive. And I think it has dominated the conversation in a way that has been unhelpful. Prices come down, these drugs are actually affordable in many countries, and the companies are invariably prepared to negotiate. There has been licensing agreements of generics and all sorts of things. We just have to be imaginative and not accept and stop the conversation that these are $1,000 a pill or whatever it is. Very few places are ever paying that. The price, these drugs are affordable, and we need to make it that our ministers for health get to be rethinking that issue of price. The actual cost of the drug is very affordable. Andrew Hill and his group have done amazing work to show these can be manufactured at incredibly low cost. And they are being manufactured at incredibly low costs, and some places are getting hold of them at these low costs. So one of the things I would be encouraging people is to rethink that issue of price, and in all of their conversations with government, to say it's actually not about the price, it's about negotiating the price and the health system that you're setting up around the price. There are countries that are going for elimination. Georgia was in the fortunate position because their health Ministry for Health was really enthusiastic about elimination of public health response. Gilead gave them the drugs, and there is an elimination program going on in Georgia, and they're aiming to eliminate by 2020. And they are doing a great job, an extraordinary job of trying to get this done. Iceland, small country, but nonetheless decided that they were going to have a go at elimination. And they too, in terms of, again, if you think a small country, but for their per head, and they're going for elimination, and they will get there probably by 2020. They'll probably get there in the next year or two. Egypt, big problem, predominantly due to the official and non-official health system, so many people infected. But they're aiming to treat huge numbers every year over the next 5 to 10 years, and essentially set, rather than just treating people they start off with severe disease, set an elimination challenge. It's extraordinary what they're doing at the moment. Australia, we're in the fortunate position where our Minister for Health at the time agreed that treatment access would become available to everybody. So we have had treatment available for us now for anybody, regardless of disease severity, how you got it, and you can be treated in community. And in the first year for Australia, we had an estimate of over 200,000 people infected, and we treated probably close to 40,000 people. We haven't got the final numbers in the first year. So with treatment access, you can do this. Treatment is being rolled out through the Asian region. I'm not going to go into details because Yatena is going to speak about this in more detail. There is variation in access across countries. But some countries are really making a big effort. Mongolia has decided to have a shot at really upscaling treatment and is trying to do their best to get large numbers onto treatment. Indonesia has a national program. I'm involved in work in Myanmar where the government for this year is going to start 2,000 treatments, as well as some private and community-based treatments. We're about to start a demonstration program in community of a rapid point-of-care test and reflex into treatment. So that is some models of care as well, though the government hopes to have 10,000 treatments the following year. Thailand, Pakistan, India is really hard to get a sense of what's going on because it's a very big country and I think needs to be thought of in terms of states rather than a single country. So you'll have some areas where it's really fantastic in India and other areas where there's less. In China, there's negotiations going on. It's in terms of trying to get details, there's access to therapy, but whether there's a clear and big program up and running yet, no. But will that be coming? And there's negotiations? Hopefully, yes. In Europe, there are many restrictions. There's variation in countries as to whether or not anybody can access drugs. So in some countries, it's a fibrosis level. In other countries, it's whether or not somebody has a history of alcohol and drug use. In others, it's related to HIV co-infection. Not a lot of it, in my view, makes a lot of sense. It's basically been really informed by where the country's capacity to negotiate. But some countries are doing well in Europe. Portugal, France, doing well and really upscale treatment, and Italy has just negotiated a really relatively low price for their treatments. In South America, the one country that I could sort of get some good information on was Brazil, and they really haven't got universal access yet, but it's being worked out, and it's hoped that really in the next couple of years that they will really be able to upscale treatment. Prices have come down. They initially negotiated a very good price, relatively speaking globally, but it was still probably too high for a country like Brazil, and so they're hoping to really upscale treatment soon though. Countries not in the Paris Climate Change Agreement or about to withdraw. The United States, I don't know whether Chris is in the audience, I just did that for you, Chris. Those three countries, the United States, Nicaragua and Syria. It's difficult to get information on Syria, they're in the middle of a war. Nicaragua has got an excellent health system, but I actually couldn't find any information. And the United States, it varies incredibly across states. And it's often driven by things to do with not being able to negotiate centrally, restrictions related to people who inject drugs, restrictions working to alcohol use, all sorts of things. So again, a bit like Europe, really not a coherent approach to how this should be done. I find it ironic that in the United States, the country where many of the companies who develop these drugs, that the prices there are probably higher than most places in the world because of that inability to negotiate. Neighbours of one of the countries in the previous group, Canada, are just about to really get much better access. It's been variable and restricted, so it's been F2 or greater, or with some specific things of less than F2. You're allowed to retreat. But again, talking to Jordan Feld, they're hopeful that really in the next 12 months they will have reasonably open and universal access at an affordable price through their health system. The way to think about this, because it seems to be a big problem, but my view is we need to think local and act global. No, it should be actually think global, act local, but never mind. So change that around. Think local, think global, act local. One day I'll get my slides right, I'm a bit dyslexic. And thinking about the role of the network. Some people are calling this micro-elimination, and what that means is in your city, do it in bite-sized chunks. Do it in some populations in bite-sized chunks. So for us, we've got an elimination program running in HIV, Hep C co-infected gay and bisexual men, where we would think that in the next couple of years we'll be able to really get the levels of infection down so low that it becomes no longer a problem in our major cities in Australia. The Burnett's working in Melbourne, the Kirby are working in Sydney to try and get that done in our two major communities. In other countries, in other places, again, they're doing these what they call micro-elimination programs. I think that's totally fair enough, as long as they're not used as an excuse to exclude key populations who are highly vulnerable. So if micro-elimination means that you don't treat people who inject drugs, and you only treat the nicer people in the population that might have got it through your health system having infected them, I don't call that micro-elimination, I call that discrimination. But if micro-elimination means I'm doing it chunk size in ways that I can cope, then I call that micro-elimination. Egypt is doing this because some villages in Egypt, the infection rates are far higher than others because of their program to treat schistosomiasis. So that meant that some villages have high incidence and prevalence and others have low. So if they go village by village by village and really think it through, as well as treating people with severe disease, they can get to elimination. As I said, we're doing in Australia where we can see that if you target certain people, you can get elimination in gay and bisexual men, and some modelling, and I think Joe Doyle from my group spoke on this yesterday. And essentially what we're seeing is that if you make sure you target, in fact, some really high-risk people, because of the heterogeneous nature of your network, you will actually get bigger bang for your buck. There's more infection going on there, but if you actually treat those right people, your impact on the network and transmission goes up substantially. I don't think we should forget that stigma and discrimination is one of the reasons why, with highly effective, affordable drugs, that this is not being rolled out everywhere. And this will impact on people wanting to access treatment because they're fearful of laws that make it against them. And this will also, we should not forget that a whole lot of us in the health system discriminate against people. And we really need to work hard to make sure that we are ensuring that our colleagues, when we speak up at the big liver conferences, when people talk about injecting drug abuse, when people talk about sexual behaviour in a way that is dismissive, that we actually call people out on that. I often think we're not quite brave enough to stand up and say, actually, I think you're wrong there. I've been at enough big liver meeting conferences and enough big conferences to know that there is still within our community of health service professionals that we need to be making, in a nice way, calling out that part of the problem is our services are discriminatory and our services have stigma. So that we need to work on this because it's vitally important if we're going to achieve elimination. So in summary, we have great drugs. Elimination is achievable. It requires a multi-pronged approach. It requires universal access to prevention, testing and treatment. We need a vaccine. The drugs are affordable and will become increasingly more affordable. It'll be other factors that become the issue for us, the cost of tests, health services in the right place for the people who need them most, and we need to reduce stigma and discrimination. Many people to acknowledge. Thank you very much for your time today.